Welcome back as we continue our journey through the digestive system. So, in the oral cavity, we left off and talked a little bit about the salivary glands. And so, now that we have the food in the mouth, we need to be able to grind it up. And so, this is where the teeth come in. We start out with 20 teeth, our deciduous teeth, or baby teeth, or milk teeth that are there. These start to erupt around 6 months, give or take. Some can be much earlier, some can be much later, all depends upon the particular child. Some babies are even sometimes born with teeth already erupted. So that can vary quite a bit. But when they do start to erupt, they're going to erupt in a particular pattern, starting with the bottom two middle teeth and then moving up and down and then up and down and up and down as they continue to come in over the next 2 years. By about the age of 6, again, give or take, some are earlier, some are later, those teeth start to come back out. And so the permanent teeth, our teeth that we're going to have for the rest of our lives, begin to erupt. And as they do so, they push out those deciduous teeth and they continue to erupt all the way up until about the age of 12 or so. And that's when we have our second molars in, the 12-year molars, and then by the age of 18-ish or so, those third molars start to come in as well. The third molars are becoming less and less in terms of mouths. They're shrinking, and so people either don't have room for them, and so they have to have them removed, or they don't even get them at all. When we look at a tooth, the tooth has some different components to it. The part that we can actually see is what's called the crown. And so this is the portion that is above the gum line. That's the portion that we can see. The root is buried beneath the gum and then into the bone. And so this is where it resides, and we can't really see it at all. Excuse me. The crown itself is covered by enamel. This is similar to what we have in bones. It has hydroxyapatites, but this is even harder than that of which is found in bones themselves. And so this is going to surround the crown of the tooth and give it its hard protective abilities that are there. Where the crown meets the root, it constricts down through neck and deep to the enamel. In the center there, we have what we call cementum. That is inside the tooth as well, and that covers over the actual root of the tooth that is there. When the tooth goes into the actual jaw bone itself, we have little periodontal ligaments that help to hold it in place there. And that allows the tooth to be held inside there. That's where when you were losing your teeth and they started to fall out, sometimes they were just held on by a little almost like thread-like structure. That was those periodontal ligaments that you were experiencing there. When it comes to taking care of the teeth, regular brushing and flossing is the key to decreasing the potential for dental caries. But even the most judicious brusher, those that brush 2, 3 times, 4 times a day, still may be susceptible to dental caries or cavities simply because of their genetics. And so that plays a bit of a role there. Also, the normal flora in the oral cavity plays a role. And so we do have bacteria that live inside the mouth, and those bacteria start to form plaques throughout the day. And so these are going to form in and around the gum line typically. If left long enough, they will start to calcify and harden into tartar, and that can then be essentially stuck to the teeth and have to be removed by picking it off the teeth themselves. But normal flossing, normal brushing will help to minimize that. If that plaque becomes too burdensome for the teeth itself, it can lead to gingivitis. So it's going to start to actually irritate the gums that are there, and so that hard calcific tartar that has accumulated there that allows for that irritation to occur. That irritant that's there can proceed from simple gingivitis into periodontitis, where the actual gums themselves are diseased. And the body is mounting an immune response towards it, and that can lead to essentially deep damage to the teeth themselves. From the oral cavity, we move our food bolus back into the pharynx. It's going to go into the oropharynx and then into the laryngopharynx as it moves down, and eventually into the esophagus. The oropharynx and laryngopharynx are designed both for food and fluids, whereas the nasopharynx was designed only for air. That's there, and so the oro and laryngopharynx can take food, it can take fluids, and air all the same, which means that it needs protection. And that protection is going to come from stratified squamous epithelium again. And so we have that extra protection along the back of the throat there to allow for the movement of foods to cause relatively little damage along the way. The pharynx is just a conduit, as well as the esophagus. It's a means to get the food into the stomach. And so the pharynx is going to allow us to divert the food into the esophagus. And then from the esophagus, we have to get from essentially the neck all the way down into the stomach, which is at the bottom of our thoracic region of the body. And so with that, we have a muscular tube. This muscular tube itself runs all the way from the laryngopharynx all the way down to the stomach, which means that it has to puncture through the diaphragm. And so it's going to go along the vertebral bodies, running behind the trachea, goes through the diaphragm, and then into the cardiac region of the stomach itself. The esophagus is just like the rest of the digestive tract. It has its tunics in terms of its layers, and it is just a muscular tube. It's all about getting that food down to the stomach itself. The lining of the esophagus begins as stratified squamous epithelium and makes its way down all the way to the stomach itself there. We have skeletal muscle beginning this process. And so skeletal muscle is at the superior aspect of the esophagus, but smooth muscle is towards the inferior aspect, which means that the upper portion is, in a sense, voluntary, and then the lower portion is involuntary. Even though once we initiate the swallowing reflex, we don't really think about the whole process of all the muscles that are involved there, but we do have muscles initiated in there. The food has now moved from the mouth down through the pharynx and into the stomach. And so along the way, the mouth has generated mechanical digestion. We've added in some saliva, and that saliva contains salivary amylase. That helped with the breakdown of starches inside the oral cavity itself. And this is part of the reason why when we do have foods that have starches, in a sense, if we chew it long enough, it oftentimes is going to start to give us a taste of sweetness. And so the more that we start to break down the starch into its sugars, we start to then notice that it has kind of a sweet taste to it. The pharynx and the esophagus just simply get the food down to the stomach. And so swallowing itself is a reflex. And so this involves 22 sets of muscles along the way. It's a very complicated process. We don't have to think about it whatsoever. We just simply move that bolus of food back towards the oral pharynx, and that then begins the swallowing reflex itself. It is in the pharynx and esophagus to begin with, and so this swallowing reflex is controlled by the brainstem, primarily the portions of the medulla and the bottom part of the pons that is there. This is going to then push down everything in towards the stomach itself. Rhythmic contractions of the esophagus continue to push the food via peristalsis down towards the stomach, and it eventually enters into the cardia of the stomach itself. So we push that food towards the back of the throat, it hits the soft palate, we start the swallowing reflex. The epiglottis is going to close over the larynx so that we don't get any food going into the respiratory tract. And then the superior esophageal sphincter is going to close. That's going to allow for us to continue to peristaltically push that food bolus down towards the stomach. And then the lower esophageal sphincter relaxes, and that then allows the food to enter into the cardia of the stomach there. Inside the stomach, we have chemical breakdown beginning for proteins. We're going to continue a little bit for a little while the breakdown of the salivary amylase, but many of our enzymes are pH dependent, meaning that if the pH is wrong, those enzymes aren't going to work very well. And so that's going to start here in the stomach with the breakdown of proteins as well. The stomach itself is divided up into some different portions, and we have some other structures that are on it. I'm going to move to the picture of the stomach here and go through those. So where we entered from the esophagus was the cardia. So that actual entrance point into the stomach is the cardia itself. Then the stomach has kind of a dome, and this is the fundus. And so this is where gases can get trapped, things like that, as we are upright. The largest portion of the stomach is the body. It continues all the way from essentially the cardia and the fundus all the way down to the pyloric region. So as we get into that area there, the pylorus itself is divided into an antrum and then a canal. As we move into the areas that are there. At the end of the pyloric canal, we have the pyloric sphincter. This is a thick muscular band. If we were feeling it on a real stomach or on a cadaver, we would be able to feel that the stomach as kind of a flimsy bag in a sense. But then once we get down into this pyloric sphincter region, it is very evident that there's a thickening of the smooth muscle there. And so that is the sphincter that's going to hold essentially everything inside the stomach until we're ready for gastric emptying. And so as we move food back and forth inside the stomach, it's going to make sure that it does not leave the stomach and go down into the duodenum. The lower esophageal sphincter is going to do the same thing up at the top. And so that's going to squeeze and hold everything inside there as well. When we look inside the stomach, we can see that we have three different layers of smooth muscle. We have a longitudinal layer and a circular layer similar to that of the rest of the digestive tract. But then we also have this oblique layer. So we have a third layer that's deep to the other two as we're looking from outside towards in. And that oblique layer is running at an angle. So the longitudinal layer runs the length of the stomach. The circular layer runs in bands around the stomach. And the oblique layer runs at an angle between the two. And this is all designed for being able to grind up the food inside the stomach, do that mechanical digestion. One of the other things that you'll notice inside the stomach is that it's not a nice smooth wall. We have what we call rugae. And so all of those ridges, all of those bumps that are inside the stomach are there for expanding the overall size of the stomach itself. So when the stomach is, in this case, essentially empty, the rugae are going to be very, very prominent and visible. As the stomach expands, they're going to become less visible. Two other structures we have: the lesser curvature and the greater curvature of the stomach. And so these lie on the inside curve and the outside curve of the stomach itself. This is where back when we did the blood vessels, we saw that we had the gastric arteries, and then we also had the gastroepiploic arteries, gastroduodenal arteries running along portions of those as well. And so all of that continuation off of that celiac trunk to feed into the stomach and then eventually into the duodenum and the spleen and everything else as well. Since the stomach has the similar layers as that as the rest of the digestive tract, here we have kind of the microscopic view of things. And so the epithelial lining of the stomach itself has goblet cells. It also has gastric pits, and these gastric pits are where we're going to have all of the gastric secretions that are going to come out into the stomach itself as well. So we have our gastric glands inside there. And then we have the muscularis layers. Again, we have a longitudinal layer, circular layer, and an oblique layer to help to mix up the food, get it into something that looks like it, in a sense, went through a blender. Those gastric glands inside them have a couple of different kinds of cells. And so we have chief cells and we have parietal cells. Those are our major cells inside there. We also have some enteroendocrine cells. So these are the ones that we mentioned before are going to produce hormones locally in the digestive tract itself. Inside those gastric glands as well, we then have the production of our hydrochloric acid. And so that hydrochloric acid is going to come from our parietal cells. And then the chief cells are going to produce another substance called pepsinogen. And when pepsinogen combines with hydrochloric acid, that converts that pepsinogen into pepsin. Pepsin is a protein digesting enzyme. Pepsin likes a low pH. So pepsin's going to work here inside the stomach with this low pH that we have in terms of the environment, and it's going to start to break down proteins. And so this is going to be our first go at breaking down proteins into their amino acids inside the digestive tract itself there. The hydrochloric acid coming from those parietal cells is released as hydrogen and chloride, so that as that acid is coming out, it's essentially not burning all of the cells along the way. So gastric glands themselves, the top portion of those glands had mucous neck cells. Those are producing the mucus that is going to provide for protection along the surface of the stomach that is there. We said again that our parietal cells secrete our hydrochloric acid for the stomach. They also produce another substance called intrinsic factor. Intrinsic factor is going to be important for the absorption of B12. And so if we don't have enough B12 production, we're not going to get intrinsic factor production, we're not going to get enough B12 being absorbed. And if we don't have B12, so if B12 is low, then we're going to get pernicious anemia. And so we don't want that either. So we need to have that happening there. And that can happen oftentimes with the elderly as their production of intrinsic factor falls. Those chief cells, their primary production is going to be in the production of pepsinogen. And as I said, it becomes activated to pepsin in the presence of hydrochloric acid in the stomach. And so that release there is going to be done based upon the presence of a positive feedback loop, which allows for that release of pepsin in the presence of proteins that are there. Some hormones that are produced by the enteroendocrine cells, we have gastrin, we have histamine, we have serotonin, we have cholecystokinin or CCK. Those are some of the important ones that are going to be released by these enteroendocrine cells of the stomach. And we'll talk about those as we go along as they function in different portions of the digestive process. The stomach, having that hydrochloric acid in it, has basically the worst job. It's a very harsh environment. We're talking about a pH of 2 in general. And so a very, very acidic environment designed to destroy anything that may try to live there in terms of bacteria, viruses. But we all know that we can get ill from bacteria and viruses that may be able to live past the stomach as well. So it's not a perfect process, especially for ourselves. And then it's also going to help with the breakdown of the food a little bit as well. That's there. In order to protect our stomach, we need an awful lot of bicarbonate-rich mucus, and that's going to coat the walls of the stomach itself. And as long as that mucus layer is there and intact, that's going to allow us to have that protection that we need from the hydrochloric acid. If something happens to limit the production of the mucus, the hydrochloric acid may start to eat away at the lining of the stomach itself. And that's where we end up having a ulcer. So the stomach is essentially kind of like a reservoir. It's going to hold the food there. It's going to take that food and it's going to both physically and chemically break it down. And so we're going to start digestion physically by doing mechanical digestion and then chemical digestion in the form of protein digestion. And for as long as the salivary amylase can function, some of those starches as well. And then it's going to deliver small amounts of that food as what we call chyme. So the remainder of the food that we see inside the stomach itself is in a chyme structure. And this chyme is going to be released in boluses down into the small intestines. And so the duodenum is going to receive the chyme. The more fats or the more lipids that are in the meal, the slower this process is going to be. That's there. And again, intrinsic factor required for the absorption of B12. So no intrinsic factor, we're not going to get B12 absorption. And if we don't have B12 absorption, then we're going to get anemia. So hydrochloric acid is important to the stomach environment, but it is impacted by a couple of different chemicals. And so we have acetylcholine, histamine, and gastrin. And when all three of them are present in adequate amounts, then we're going to get adequate production of hydrochloric acid. So that means if somebody was taking an antihistamine, they may also impact their production of hydrochloric acid. And so as we move into allergy seasons, things like that, somebody has allergies, they may be taking an antihistamine, and that antihistamine may lead to a decrease in their overall hydrochloric acid production. That's there. So one of the things that may be a consequence that we know as a side effect of taking a particular medication that's there. So again, we need our gastrin, acetylcholine, and histamine to be able to bind to those parietal cells. As they bind to the parietal cells, that's going to induce the release of hydrogen ions out into the stomach. And we also need then our chloride ions. Those two are going to mix together and generate our hydrochloric acid. And so that moves along through the gastric pit, up and out, and into the actual opening of the stomach lumen as we need hydrochloric acid production to occur. And then again, all along that lining, we're then going to have bicarbonate-rich mucus that's going to help to protect the stomach in or from the hydrochloric acid that's there. The three layers of the stomach muscles themselves are going to allow for peristalsis. That's going to essentially move as we kind of see our stomach. The food is going to move back and forth and back and forth as we mix the stomach up. and that's going to occur in waves that are moving down towards the pyloric region, and that allows at essentially a wave rate of about 3 per minute. So every 20 seconds or so, a new wave of contraction is occurring along the stomach itself. That's there. That allows for all kinds of mixing. And so we're going to mix up the contents of the stomach with those enzymes. We're going to mix it with the hydrochloric acid that's there until we have a nice liquefied chyme in terms of the amount of, or the type of substance that we have. That moves back and forth, and then in small increments, that chyme is then going to be released into the duodenum. So peristaltic waves pushing down, the pyloric sphincter stays closed. At some point, usually about 30 minutes or so after ingestion has occurred, depending upon the contents of the food itself and what it's like, it may be sooner. During some of those contractions, the pyloric sphincter is going to open. And so now this is going to allow some of the chyme to enter into the duodenum. A little bit at a time. Again, the more lipids that are there, the slower this process is going to be. So it's going to take a little bit longer for things to empty out there. So that emptying is regulated by nervous activity in terms of what we call the enterogastric reflex, and then also hormonal activity. And so this is going to be coming in from the duodenum and the stomach, feeding back and forth on one another to create either emptying or inhibit that emptying as the duodenum is filled. So when we have the duodenum filled, that feeds back into the stomach and inhibits secretions coming down from the stomach itself. So we're going to stop that process. As I said before, the more fat-laden that chyme is, the slower that it's going to occur. The more carbohydrate-rich, the faster things can go. So if you have a carbohydrate-rich meal, basically all just carbs, and basically no fats in it, that's going to move from the stomach much faster than that of a lipid-based diet in terms of the meal itself there. The first of our accessory organs that we have in the peritoneal cavity is the pancreas. And so the pancreas itself is kind of tucked in behind the stomach. It goes from the lesser curvature back towards the greater curvature of the stomach itself. That's there. The head is nestled right in the hook of the duodenum and the stomach pylorus. And then the tail goes all the way out towards the spleen. And so it makes its way out through there. The pancreas is vital because it secretes almost all of our digestive enzymes. And so digestive enzyme production and release is essentially the exocrine role of the pancreas. We talked about the endocrine function back during the endocrine system when we talked about the production of insulin and glucagon. And so integral to the regulation of blood glucose levels. And when we talked about the pancreas before, we were talking about those small little islets of Langerhans in relation to the pancreas. And we said that the majority of all the pancreas were these acinar cells. And so we had these acini all throughout the pancreas. And their job, again, is to produce digestive enzymes. And so these granules being released have those enzymes in it, and they're going to feed into ducts. Smaller ducts are going to feed into larger ducts until we eventually enter into the main pancreatic duct of the pancreas. The enzymes themselves are there for the breakdown of our foods. And the duct itself, in terms of that main pancreatic duct, is going to end at the hepatopancreatic ampulla. But it's going to join the common bile duct coming down from the gallbladder and the liver. And so the two of them are going to essentially join one another the pancreatic duct, the common bile duct, and then the hepatopancreatic ampulla. That's there. So pancreatic, the common bile, and then the hepatopancreatic ampulla as they join together there. And a little bit better drawing than what I have. Again, the pancreas is feeding into this main pancreatic duct. It's going to be joined by the common bile duct, and then we have a little portion where we have the hepatopancreatic ampulla, and that's where the two sets of juices essentially exit. The pancreas does have an accessory duct where it is not connected to that common bile duct, and it's going to just release pancreatic enzymes by itself from that particular duct there. Slightly different view, and I like this one simply because we can see the hepatopancreatic ampulla a little bit better that is there. And so the pancreatic duct, the common bile duct, both of them joining together at that ampulla, and then we have the sphincter that's going to control the emptying of those enzymes into the duodenum. Here again, you can see nicely how the head of the pancreas comes into the hook of the duodenum here. Essentially, it's been cut off at the stomach itself, and the stomach would be basically lying right over this, and then the spleen would be over in here. So when it comes to the production of these enzymes in the pancreas, similar to that of the enzymes of the stomach where we had pepsinogen released, pepsinogen was a inactive enzyme. We want the same thing here in the pancreas. So we're going to have enzymes that are released in an inactive form and then activated in the duodenum itself so that we're not digesting the pancreas. In addition to those enzymes, we're going to need a fluid that has the ability to buffer the acid from the stomach. So it's going to neutralize all of that acid, and we're going to take our pH and rise it up. And so we're going to leave that pH of 2 and head back towards neutral. And so we have totally different pH, which means the enzymes that are functioning here are going to have to be enzymes that are able to function in a higher pH rather than a lower pH. And one of those is trypsinogen. And so trypsinogen is for protein digestion, and pepsinogen likes a higher pH compared to that of in the stomach of pepsinogen. So trypsinogen gets converted into trypsin. Trypsin works at a higher pH. Pepsin works at a lower pH. So two completely different components there. Pro-carboxypeptidase, and then eventually carboxypeptidase as our active enzyme. Another example of an enzyme for breakdown in the small intestines as well. And then we have a whole litany of other enzymes. At this point, you don't need to memorize all of the enzymes that are being produced by the pancreas itself. That's there. But essentially, all the other enzymes that we have are going to break down everything that we can. As long as we have an enzyme for a particular substance, we can break it down. And so we have those for lipids, we have those for our sugars that are there, and we even have it for the DNA. We have our nucleases, so we can break down nucleic acids also. When the pancreas does not release its enzymes out of it and they become activated, we get pancreatitis. And so one of the more common causes of pancreatitis is that of alcohol abuse. Oftentimes this is going to be in the form of kind of a binging type of a drinking that has occurred. It can also arise from things of a backup of the system, from things like gallstones. And so if a gallstone gets trapped in that hepatopancreatic ampulla, or even at the distal end of the common bile duct, that may block the release of pancreatic enzymes, and they become activated inside the pancreas, and that then leads to the pancreas essentially digesting itself. So not a good thing. This is a emergency situation. All ingestion of foods needs to be ceased until the pancreas starts to calm down in a sense. Next time we'll pick it up here with continuing into the small intestines.